Ivo, we hear you now.
Fantastic, it's very well. Sorry about interrupting your extremely interesting discussion, but in fact I have a personal opinion in for this topic. Ralph mentioned that the femoral approach complication rate is very low, but in fact, to be fair, the radial approach is even lower. So in nowadays practice, there are more and more interventional practices all over the world doing routinely carotid interventions, both sides, right and left, by radial approach. And in fact, Professor Velchev have shown such a case with radial. So with the radial approach, the complication rate is even extremely low. And experienced operator hands, many procedures above the arch can be done by radial.
Okay, well, please, let's go to your case.
Okay, thank you very much. In fact, I will update what is my team. After that, I would like to ask Dr. Janevska to share with you what is the clinical and anatomical situation before showing you what we have done. Our team, Dani, the nurse, one of the most experienced nurse, and Tiska together, Lydia, the X-ray technician, and of course, Dr. Stankov, who did the main part of the job. And in fact, I came, you probably remember 10 minutes ago, I was in the room with you, and I came to open the stent graft. So, so I will ask now Dr. Janevska to tell us and you what is the case about.
Yes. The clinical case is a 73-year-old male with general atherosclerosis, with cerebrovascular disease, peripheral artery disease, arterial hypertension, and dyslipidemia. Presented in clinics with TI and claudications. Risk factors is male, age, and smoker. This is the color Doppler ultrasound and IBA index with 70% stenosis of left vertebral artery with elongations, normal blood flow and full patency after stent implantations of right carotid internal artery, with massive calcinosis of abdominal aorta with pariateral thrombosis, pariateral thrombosis of common iliac artery, and thrombosis of both superior physeal artery. The ABA index in right one is 0.66, in left one is 0.58. This is the Doppler result with shaggy aorta with 33 maximal millimeter diameter and 70% stenosis of left vertebral artery. This is the reduced blood flow in the tibial artery, and this is a result from a CT aortography, diffuse dilatation of the aorta with penetrating ulcus of the aorta arch, with parietal thrombosis, most prominent in the infrarenal segment. And now, let's see the live case, Professor.
Okay, thank you very much, Dr. Janevska. In fact, this polyvascular patient with shaggy aorta and history of carotid intervention, and also pathology of the lower leg arteries. In fact, as she mentioned in the screening of the brachiocephalic vessels and the aortic arch, we have seen on the CT this huge ulceration with the contrast reaching almost the end of the ulceration, very close to the cap. So it's no doubt it's imminent rupture. And in this situation, in fact, this is in the scope of aortic dissection. In fact, this is the beginning, as an evolution, this is the beginning of the aortic dissection. By anatomical point of view, you probably observe on the screen on the road map that this ulceration over the small curvature of the aorta is just below the subclavian artery. So there is no landing zone. You know, I'm absolutely sure you know that we need at least 2 centimeters. So we need 2 crowns to be proximally from the proximal part of this ulceration. And in this situation, it's even more complex. Why? Because in the context of his polyvascular pathology, the right vertebral artery of the gentleman is occluded. And you probably remember several hours ago discussing about the coverage of the left subclavian artery without protection. It's more than obvious in this situation it will be not unethical, it will be a crime to cover the left subclavian artery because the gentleman has only one vertebral artery, the left vertebral artery, the right one is occluded. And in this situation, also in the context of the discussion that we had with Rania, Dr. Prevenza, we decided to put a chimney stent graft, a big graft, following the measurements of the left subclavian artery. We decided to secure the flow into the subclavian and the left vertebral artery before the implantation of the stent graft. And I will ask Lydia now to move since the first and second and third in order for you to show, in fact the access. So we have triple access. As you can see, we have the right radial access for the pigtail put into the ascending aorta. We have the left brachial access in order to have the possibility to put the chimney, the left subclavian chimney, the big graft. And of course the femoral 20 French access that we are using for predilation of the femoral artery before putting sheetless. This is our common practice. In TEVR cases, in more than 90% of the cases, we put the stent graft sheetless. So we are opening the femoral artery with a big sheet, and after that we put sheetless. You see now the big graft coming from the sheet through the left brachial artery, and will be positioned soon. Next please. In left oblique position, you see the position of the big graft of the chimney. In fact, and this is the exact position of the tip of the big graft to protrude several millimeters above the covered part. This is a stent graft with the aortic stent graft with a free flow. So we have the first crown is free of tissue, so it's only metal stent. The first crown is only metal stent, the so-called free flow, only fixating the graft toward the vessel, toward the aorta, but without coverage. So since the small markers there, distally, it's the covered part. So the aim is the big graft to protrude just several millimeters above, proximally to the covered graft. Next. So this is the position. Next one. Okay, this is the exact positioning. Next, and we like very much working on the roadmap. Next, please. And you are going to see now the opening, the slow opening of the Valiant. Next, please. And this is the graft opening with rotating the knop. And finally, with sliding the distal. After the first 2 crowns of the cover part I open, we can slide. So first we rotate, and after that we are sliding. Next, please. This is the ballooning of the big graft. You see. Next, in order to make a small invagination into the aortic stent graft. It's a chimney with the vent technique. It's something in between. Next. And you are going to take a look, and this is the removal of the delivery system of the aortic stent graft. Next, please. And now you are going to see one projection in left anterior oblique to show the flow into the subclavian and to the carotid and brachiocephalic trunk. Okay, and this is the next one in AP position to show the good coverage of this aortic ulceration and the total resolution of the ulceration and the centralization of flow. Some questions up to this moment?
I don't think there's any questions, Ivo. It's very clear that you've got excellent flow up the left vertebral on the angiogram we can see in the room. And we can also see that the ulceration has been excluded. So we see a very clear and good result on the screen here, Ivo.
Great, thank you so much. And in fact, finally, we did an injection into the subclavian artery absolutely by purpose in order to take a look on the left subclavian. Next, please. Yeah, this is the injection on the subclavian to see the vertebral. Next. And also we opacified the intracranial vertebral in order to prove that the left vertebral and the basilar and posterior circulation is absolutely protected. And now, if you want, we have several, in fact, one step more, and this is to close the femoral approach by the large bore manta, because in fact it's a 20 French sheet. I mentioned already that we have used the 20 French sheet only for predilation. In fact, the stent graft itself is 24, so we have used the sheetless implantation, sheetless implantation. And now, in fact, we did a small trick for the manta. We exchanged the Lunderquist wire. We are fan. All the team are fans of the Lunderquist wire because it's, in fact, giving us excellent support without any problem with the movement of the large bore devices. But unfortunately, because it's too stiff, with the manta, in fact, the valve of the initial localizer of the manta is bleeding too much with the stiff wire, and because of that we interchanged and we put more gentle wire. And you probably, in case the camera is coming closer, yeah, it's very well. See, there is in fact no bleeding, zero bleeding with the Stork wire. It's a floppy wire, much more gentle toward the valve, and because of that we don't have even one drop of blood going outside. And this is step by step. So the localizer is already inside, and this is in fact the anchor and the plug. And following the measurements in the with the measurement sheet, I know that the level of opening is
3.5.
3.5 total. So it's a 2.5 measure plus 1 is 3.5. So after taking a look at the numbers here, 3.5.
Задръжте за секунда.
Yeah, at 3.5. Yes, you see it. Here is 4. So I'm on 3.5 at the skin now. So I'm going up at least 45 degrees, even a little more, going with the lever up. This means that the anchor is already open inside, and after giving some time to the sponge, the collagen sponge, to have contact with the blood absolutely by purpose in order to be activated, with the pusher, I'm going up, and the pusher down. So it's a pull, push, push, pull, pull, push. And after doing that, we have, in fact, in this 20 French sheet, this result. So this is the result. No compression. In this situation, we can remove the wire. And in fact, we are cutting the suture just above the skin. And we are done.
Fantastic, Ivo.
This is the femoral approach. already closed. The patient is doing very well. Of course, he is under conscious sedation, no general anesthesia. He is absolutely conscious now and in a good shape and very good hemodynamic, absolutely normal hemodynamic. No problem. And I think in 5.5 minutes of X-ray time and about 27-30 minutes of procedural time. And how much contrast? Let me see. It's 81 milliliters of contrast injection. So this is the expenses, time and contrast expenses to do this case.
Good, Ivo. Ivo, excellent case. Thank you.